We're recording. Hi, my name is Kelly Springer. I'm an attorney at the Willenbring Law Office. We have offices in Cold Spring, Avon, and Albany, but we serve entire Minnesota. We're a full service practice, basically doing everything except for bankruptcy and criminal law, but anything like that we can help folks with. I focus a big chunk of my practice on estate planning and elder law, which includes healthcare planning. And I'm really happy to have Dr. Chris Wenner with me today from Dr. Christopher J. Wenner, MD, a professional association, to talk with me about healthcare directives today. We were going to do a live event for National Healthcare Directive Day today, but that's not going to work out. So technology is here, and we're going to do it this way. So Chris, why don't you tell us a little bit about you and your practice, and then we'll jump in.
Great. Well, thank you for having me, Kelly. And this was something that Kelly has been working on for some time. And I really think that this is an admirable event that we're having virtually. It would have been nice to have it in person, but given the times, I think that this is very good. And certainly I think that a lot of us have opportunities to do things that maybe we've been putting off. And so I think that this is a very appropriate time to deal with this. As Kelly mentioned, I'm a family physician in Cold Spring. I deal with the young and the old, and I think advanced directives, living wills are critically important. And I can share a story with you whenever, Kelly, you think it's appropriate, as far as just driving home the point of why that this is an important thing for not only you, but for your loved ones as well. But I'm pleased to be a part of this today.
Great. So National Healthcare Directive Day, as you know, Chris, is really intended to get people to do these documents. And so basically what a healthcare directive is a document where people do two things. They decide who they want to speak for them if they are unable to make decisions, whether because they're in a coma or they're, in dementia, something of that nature. So they decide who their decision maker is rather than letting a court decide for them. And then they can specify what their wishes are regarding healthcare and end-of-life issues. So the form that we've been using in my office to help people do this is from the Twin Cities Medical Society. It's called Honoring Choices. If people go to Honoring Choices Minnesota, just drop that into Google. They have it, I think, 6 or 8 languages, and it's a really intuitive form. I know that's the main one that the Centricare system uses, and that's the biggest health system in our area. But let's just talk a little bit about healthcare directives. From a legal perspective, we always tell people, this is a way for you to make decisions while you still can. Otherwise, other people are going to make them for you, and it may not be what you would have wanted to have made, if you were standing there making that decision for yourself. So just as a medical professional, tell me a little bit about your experience with healthcare directives generally and what they mean to you as a medical professional looking at one of those.
So I think this is a good opportunity for me to share this anecdote that I have, just so our listeners can understand the importance of this. And so early in my practice, I was called to the emergency room about a young patient of mine who had a stroke. And this patient was not able to respond to any sort of questions at all. And she was rapidly deteriorating and in the need of a breathing tube to help her breathe. She was in the need of a breathing machine. Her blood pressure was very low. She was in need of medicines to keep her blood pressure up. And in a sense, she was critically ill and in danger of dying if medical intervention didn't take place. And so the patient was in the emergency room, and I turned to her daughters and said, what do you want us to do? We have this opportunity to do these things to your mom. And they looked at me with this wild-eyed look and said, we don't know. We've never had this discussion with our mother. And so really what it did is it made a really challenging situation that much more challenging. And I think that's the important thing that people need to take away from this, is that death is not easy for loved ones, but we have the potential or the opportunity to make it maybe a little bit less taxing by expressing our wishes. And so I really think that that is the key purpose behind this, is making a challenging situation a little bit easier.
I know I have found that this is the document that my clients struggle with the most, because it is those deep questions. And one great tool that people can check out is there's a nonprofit called the Conversation Project, and it's got a lot of great tools to help people have that conversation. It's not the most comfortable conversation you're ever going to have in your life, but it gives you a way to they've got even like a little worksheet that can help you think about what you as an individual need to think about, and then help you discuss that with a loved one. They've also got some kind of humorous videos to help you kind of how to even bring that up, whether you are the person making the directive, or maybe you're a child trying to talk to your elderly parent or something of that nature. It's a really useful tool. Now, Chris, a lot of people have questions about what different treatments are, things of that nature. And we're going to dig into the form in a few minutes. But if somebody wanted to book an hour of time with you, if you were their doctor, and go through a form like that, is that something that you do for clients, or that you recommend people do if they're concerned about these things?
I do, Kelly. And so one of the under some of the new Medicare guidelines is that Medicare recognizes the importance of this as well, and will actually cover that as an office visit. In the past, they hadn't covered such things, but I'm certainly happy to do that, sit down and talk with some of the specifics about patients, or with patients, about questions that they might have, and I certainly do that on a regular basis. That being said, what I tell my patients is there's no right or wrong answers to it. And really, this document needs to be from the heart. It needs to be how they feel. And that carries just as much weight as, which boxes to check and that sort of thing, as far as, getting at, this is, how I feel about my health now. This is how I would want to be treated if X, Y, or Z happened. This is what's important to me. I think those things, anybody can write those down without you or I sitting down and talking with them. They just need to do that.
Sure. So when we look at the form that we work with, the first thing, of course, that you do is you choose who's a primary and a backup decision maker. So, certainly from a legal perspective, I'm telling people to pick the person that they feel will honor their wishes, that understands their wishes and is able to make those decisions, in what could be a chaotic situation. Do you have any suggestions from the medical side about what kind of a person is a good choice for a healthcare agent or decision maker?
Well, I think we know, our loved ones, we know who may struggle with implementing our choices. So I've had family or people come in and they say, my daughter, I know that she would not, institute a do not resuscitate order if I was in that scenario. Well, then that person probably isn't the one that you want to have as your healthcare agent.
Sure.
I think, making sure that your healthcare agent is, understands what your mindset is.
Sure.
And the other thing is, and so I think that's probably important. I think the other thing is that your physician can't be your healthcare agent. And so I get asked that on a regular basis if I can be somebody's healthcare agent, because we spend a lot of time talking and I feel like I do understand my patient's wishes, but as a physician, I'm unable to provide that service.
Sure. And so, assuming someone gets over that hurdle, they pick a family member, a friend, whoever they think is the best decision maker for them. The main things that a healthcare decision maker does, and you can jump in as well, of course, they're making decisions about what treatments a person has, things that they don't have. and, trying to interpret any wishes that the person has to the medical providers such as yourself. From a legal perspective, our form is geared to give them access to patient health records. Otherwise, HIPAA, which is the Health Information Patient Protection Act, prevents them from doing that, and that can cause a lot of issues if they don't understand the history. From a bigger perspective, if you're dealing with elderly people or disabled persons, it allows you to choose a facility if they need to be in a residential setting. It could be a nursing home or something of that nature, and certainly make decisions about, if the person has passed away, organ donation, things of that nature, those kinds of things. Would that be a good summary of generally what a healthcare agent does, or do you see other things that a person would normally do if they're empowered under this form?
Yeah, I think that would be a pretty encompassing definition of what an agent would be from my standpoint, Kelly.
So our form also has a section where you can give additional powers outside of that base set that you get. One of the things that a person can choose is, it says, making decisions about the care of the body after someone passes away. And I know from a legal perspective, I think about, release to a funeral home, things of that nature. But from a medical perspective, are there things that would allow someone to consent or not consent to by having that power?
Yeah, that's a good question, Kelly, and I guess it hasn't come up, so I can't think of any reason why that would be, helpful from a medical standpoint.
Possibly autopsy, maybe, if that was necessary for some sort of reason.
Yeah,
something like that, maybe.
Yeah, I think that would certainly, I guess that would be.
Okay. So of course, the toughest part of this form is once you get past that initial section, you're starting to indicate what your preferences are. And the first section of this form deals with cardiopulmonary resuscitation, or CPR, as most people understand that. And then we have three choices here. It's the person wants CPR, they do not want CPR, so a do not resuscitate, or sort of a middle of the road, what does my healthcare team say? Can you tell us a little bit about what CPR is and maybe situations where people would want it and maybe they wouldn't?
Sure. Yep. So CPR, as you mentioned, Kelly, it stands for cardiopulmonary resuscitation, and it's a way of reviving people if their heart has stopped or their breathing has stopped. And so cardiopulmonary resuscitation typically consists of a breathing tube into the throat, followed by mechanical ventilation, so using a ventilator or some sort of device to move air in and out of the lungs. That's accompanied by chest compressions, which serves to circulate the blood throughout the body. That's CPR in a nutshell. Those two things is ventilation and circulation, and then obviously there's medicines and things like that that we can give intravenously if we have the capacity of doing it. But those are the two things. Oh, I'm sorry. And then shocking the heart if need be. And so AEDs, automated external defibrillators, are becoming quite ubiquitous in our society, which is a wonderful thing. And they serve to shock the heart if the heart is in a rhythm that is not circulating blood throughout the body. So that's the other component of it. And CPR, or cardiopulmonary resuscitation, is a very effective tool if applied properly. If applied incorrectly, it's it has minimal benefit. Sure. And there's some significant consequences that can come about from CPR. The trauma associated with putting in a breathing tube, the trauma associated with chest compressions. So it's not something just to be taken lightly. It's not like, taking a Tylenol for a headache or something like that. I mean, there's some significant potential ramifications. And so I think it's a good first step for people to decide, do they want to have CPR or not? And the hypothetical that I give to my patients is, if you fell over on my office floor right now, from a heart attack, would you want us to do everything to resuscitate you? And that's kind of the decision tree right there is, yep, I would want to do everything I could to get over this heart attack, or nope, that's my time and I wouldn't want anything done. Obviously, this form on the section 2 has that second paragraph that you referenced, Kelly, about if my health were to change in the future, which allows for a little bit of direction from the healthcare agent, within this. But for most people, identifying, one or the other is the important first step.
Sure. And I know sometimes when I'm dealing with people who are more elderly or frail, is there a certain point where CPR can be more damaging than helpful? I mean, I've heard things such like you can have ribs broken and other things that can happen. Obviously, it depends on the scenario and when and where it's happening. But a lot of people ask me that as they get older, is that something that's going to be more damaging than helpful?
Correct. Yep, you're absolutely right, Kelly. And so I certainly counsel my patients that if you are elderly, frail, and we do CPR, there are oftentimes broken ribs that are, a result of that. It's a fairly assertive maneuver that certainly can have some consequences. And so, yes, it's important to understand what that can do to one's body.
Sure. So the next thing, as we go through this form, if people have specific healthcare conditions, they can specify those. That's certainly individual. But then it starts talking about IVs, feeding tubes, and other types of intubation. Can you tell us a little bit about what those treatments are? Because a lot of my clients struggle with, what does that even mean?
Sure. So an IV is an intravenous line. Most of the time it's put in through the hand or the arm, and it's to administer intravenous fluids, which can help if one is dehydrated, one's blood pressure is low. We can also administer antibiotics and other medicines, via the intravenous line. That would be a typical intravenous line. Sometimes the people are critically ill. We have to do what's called the central intravenous line, which would involve a tube going into the neck or underneath the collarbone. Those are both called central lines and certainly much more invasive than a typical peripheral intravenous line. Okay. Intubation was the other thing you asked about, Kelly, and again, that's part of CPR, but it can be done outside of CPR as well. We've all heard lots about intubation and ventilators with this coronavirus pandemic, and basically it's a breathing tube that goes into the throat, into the windpipe, and sits down near the lungs and serves to provide fresh oxygenated air to the lungs, and then serves to get rid of the air that has carbon dioxide in it, which is the byproduct of our respirations and our metabolism. For that sort of procedure, you can't be awake, so you have to be sedated. So you're going to have an intravenous line, and you're going to have medicine to keep you sedated, because obviously having a big tube down your throat and into your lungs, we don't tolerate that. We gag and cough and that sort of thing. So you're sedated significantly with medicines with that.
Sure.
And I forget what your third question was, Kelly. There was IVs.
A lot of my clients are concerned about feeding tubes. Something happens and they can't eat or whatever. I don't know how common something like that is, but a lot of my clients are concerned about that. Can you just talk about that for a second?
So there's two basic types of feeding tubes, Kelly. So there's a feeding tube that can go into the nose. So it's a tube that goes through your nose, and then it goes down your esophagus, your food tube down into your stomach, and that's called a nasogastric tube. And it's a short-term feeding solution. So if somebody has a fairly reversible course, and we just need to give them some supplementation, some nutritional supplementation, that's an easy thing for us to do. And then when the patient is taking nourishment, again, then we simply pull that out. The more permanent type of feeding tube is a tube that goes through the stomach wall or through the abdominal wall into the stomach. and it's called a percutaneous percutaneous endoscopic gastrostomy tube, or a PEG tube. And so basically a tube is put in through the stomach or through the abdominal wall into the stomach, and then we're able to provide nourishment that way. It's a much more permanent solution than the nasogastric tube.
Gotcha. The other thing that this section contemplates is medications for pain and comfort. And can you talk just, kind of high level about what types of medications maybe that people would use at a such time like that? And maybe talk a little bit about what palliative care is, because that's going to be something that's contemplated in this section that people are going to be considering when you're looking at life-prolonging treatments versus palliative care.
Sure. And so palliative care is purely a term to keep people comfortable. That's all that palliation means, is to keep people comfortable. And I think a lot of people are afraid of palliative care because it means that, okay, that's it. Somebody's going to, accelerate my death. And that is not what palliative care is at all. Again, it's to keep people comfortable. And we have lots of good pain medicines, medicines to help people feel comfortable if they're in a dying process with palliative care. A lot of patients are fearful of narcotics. They're fearful of benzodiazepines because they've heard that, okay, this is going to make me die quicker. That's not the case. It's purely to keep people comfortable. And, one of the things that oftentimes my patients will put in their advanced directives about the dying process is they don't want to be in pain. They don't want to be feeling like they can't catch their breath. And if anybody's ever been short of breath, had a hard time breathing, you can imagine how anxiety provoking that is. And so thankfully we have good medicines that are available to help relieve shortness of breath that can come about with dying. And we have medicines that can, be very helpful in treatment of pain with the dying process as well. They don't accelerate the dying process. This isn't euthanasia. This is purely, palliative care.
Sure. So after a person has passed, once that's happened, the next section that this form contemplates is organ donation. And let's just dispel the myth right now. If somebody is an organ donor, that doesn't mean that their care team is not going to give them all the care they need. Is that correct?
That's correct. Yeah, there's nothing with that at all. And in fact, in times of brain death, oftentimes people will be kept, if they're an organ donor and they have organs that are useful, we'll keep them alive longer on breathing machines and that sort of thing. So it's not as though we're, expediting the death process to get the organs. No.
Sure. Do people ask you a lot about that? Like what the process is, whether they should? Do you have any thoughts or advice for folks about organ donation?
Yeah, I honestly, I don't get many questions about that, Kelly.
Okay. This form, this one trips my clients up a lot, and I'm not sure what to tell them either. It asks if a person wants an autopsy when they've passed away. I can't think of too many situations where that would be necessary, but perhaps you could enlighten us when a person might elect to have one done after they've passed away.
I guess if they feel like their spouse was poisoning them or something like that, maybe, but I don't know, Kelly, honestly, I don't think that there's necessarily, there's very few times where we need to do autopsies. And so for somebody to state that, preemptively, I guess it doesn't make a whole lot of sense to me either.
Okay. Other than sort of those concrete areas dealing with resuscitation, medications, things of that nature, there's a lot of general questions in this form. And so from a medical perspective, are there things that you think it would be helpful for people to share on a more general basis about healthcare and end-of-life issues that you think would be helpful for decision makers at the time they're having to make those big decisions?
Yes, I do, Kelly. And I refer patients to page 6 or part 3, my hopes and my wishes. And the part 3 begins, I want my loved ones to know my following thoughts and feelings. And the first is, the things that make my life most worth living to me are. The second is my beliefs about when life would no longer be worth living, my thoughts about specific treatments, my thoughts and feelings about how and where I would like to die. Those 4 subjects, I think, are very critical because they can cover the gamut of things and really allow the healthcare agent to tailor the patient's care according to that. So for example, under paragraph 1, the things that make life most worth living to me are, oftentimes people will say, if, I can't have a conversation with my family with, normal cognition, that's the most important thing to me. Or if I can't eat, my ham sandwich and I'm dependent upon a feeding tube, that's, the most important thing to me is to be able to eat. So those first 2 paragraphs really tie together the things that make life most worth living and things about when life would no longer be worth living. I think that having patients expand upon those 2 are really of great value for the healthcare agent. My thoughts about specific medical treatments, and this is where patients have specific anxieties about certain things, that can certainly be listed there. And then my thoughts and feelings about how and where I'd like to die. And this is really a thing that families have a hard time, getting to this, but patients often have, a concrete idea where I'd want to die. I want to die at home, or boy, I can't think of a worse place to die, and I want to die at the hospital, or I want to die wherever and however. But really having that well defined is another critical part of this document.
Sure. And kind of bridging off that topic, a lot of people are confused about what hospice care is. Can you tell just a little bit about that? Because I think that's becoming more and more common.
Sure.
How does that differ from hospital care or those kinds of things?
Hospice is it's simply a different way of looking at one's care. It's not, the treatment goes from curative or treating a disease to keeping a person comfortable. So by definition, hospice is somebody who has 6 months or less left to live. Okay. Now, obviously, none of us have a crystal ball. We don't know, when ultimately we're going to die, but most medical professionals can have a pretty good idea of, it looks like there's 6 months or less left to live. Hospice it's not a place, it's not a thing, it's just it's an adaptation of a different way of dealing with illness. So there are hospice agencies that provide hospice care. And so there's a number of hospice agencies locally. You can receive hospice cares at your home. You can receive hospice cares at a skilled nursing facility, i.e. a nursing home. You can receive hospice cares at an assisted living. You can receive hospice cares at a hospital. You can receive hospice cares at a hospice house. And so there's lots of different ways to deliver hospice cares. But again, it's a different mindset. It's a different way of thinking. It's not, I'm treating this disease. It's, I'm accepting of this disease. I'm accepting that likely I am going to be dying within the next 6 months. And I want to make these next moments that I have as meaningful as possible. And so oftentimes when I counsel people about hospice, they've been up to their eyeballs in chemotherapy and radiation and surgery and that sort of thing, and they're tired and they feel horrible and they're not talking with their family because they're so tired all the time. And so a shift from treatment to keeping people comfortable oftentimes provides a wonderful experience for that patient and their family during their last moments.
Sure, that makes sense. Of course, the next part of the form is more person specific. It's talking about religious preference and things of that nature. I think that's pretty standard. Then we get to the point where, okay, somebody's gone through the hard part, they finished the form. From a legal perspective, now there are two ways to make this form legally effective. It has to be signed and dated, of course, by the person who did the form, either in front of a notary, which is hard right now because of the coronavirus epidemic, or in the presence of two witnesses. And this is the only document from an estate planning perspective where it is okay for those witnesses to be what we call interested, like family members or someone like that, because that's most often where people, if people are signing in front of witnesses, that's who's there. Sometimes they are already in a hospital setting, and maybe the notary isn't around or whatever. That's okay. And as long as you have two witnesses who have actually seen you sign this form, you don't have to have a notary. And I think sometimes that's confusing for people. So it could be your spouse and your son or daughter or something of that nature. If you have that, that's just as effective as a notary stamp.
Kelly,
In those situations.
Kelly, could a healthcare agent who is listed, could they also be one of the witnesses as well?
They can. It's not ideal. We try to avoid that when we can, but Minnesota law does allow that the healthcare agent is one of those witnesses because at least there's another one besides that person. We try to avoid that when we can, just in case there's, particularly if we know there's conflict in the family, but most of the time there isn't. And then it can be whoever is available at that time. If it can be two other people, that's better. If we ever get into a a legal contest over it or something of that nature. Sometimes, Chris, so we've been through the form. Once the form is completed, I encourage my clients to take a copy of it and hand it to you or to whoever their primary medical provider is, so that that is on file with them. And in some linked health systems, maybe it gets entered into a patient record. Is that something that if, say, they put it on file with you, they end up in a care setting, that's something you could transmit to another facility? Or what do you recommend people do with these documents once they're completed?
Sure. So what I tell people to do is I like to have a copy of the completed form, and then I forward it on to the hospital that's most geographically close to them. So most of the time it's going to go to the St. Cloud Hospital for folks locally, and send it off to their medical records department. But I encourage whomever to complete the form and then get the form to your primary care doctor, and then your primary care doctor will direct it to the appropriate hospital.
Oh, great. I didn't know that you did that, so that's good for us. I know occasionally we have done the same thing when we have been contacted by a medical facility, because nobody else had a copy of the form except for us, because we also keep copies of those as well. Now, every once in a while, Chris, somebody will come, they will fill out a healthcare directive, but ultimately, from a legal perspective, some of those healthcare preferences they specify from a legal perspective are advisory. The healthcare agent can do something different if they wish, because ultimately, sort of the legal theory is the healthcare agent at the end of the day is the one who's going to have to live with that decision if the sick person happens to pass away. So that's something I always caution people. If they have a strong preference or they are concerned maybe that their kids can't make a do not resuscitate decision or something like that, there's another step people can take. Is that correct?
There may be, Kelly. I guess I'm not necessarily aware of that. Again, I think it just gets back to the importance of having a healthcare agent who you feel is somebody who's able to respect your wishes. That being said, I think that if one's document says, I want X, Y, or Z done, and the healthcare agent has views that are antithetical to that, I think we as medical providers would call into question, well, what's going on here? Because if it's markedly discordant, we would probably look at that and investigate it further.
Sure. So I have a few clients who have done the POLST form. It's a provider orders for life-sustaining treatment or lack thereof. Is that something that you have a lot of experience doing with folks, or is that something that's done in a different setting. Do you know much about that form?
Sure. Yep, I use it quite a bit, primarily for my patients who are in long-term care facilities.
Sure.
It defines some of these treatments a little bit more objectively. So do you want to have an IV put in? Yes or no. Do you want to have intravenous antibiotics? Yes or no. And so there's a checklist of certain treatments that the patient can adapt to. It's much more of an objective document, a defined document, as opposed to this honoring choices document, which is much more the spirit of what the patient wants.
Sure. And so if there's one of those on file in addition to a healthcare directive, would that be a more controlling document in a care decision scenario, or how does that work on the medical
again,
side?
if they were discordant, I think we would look at that and and have to dig deeper as to why they were markedly discordant. But usually they're fairly uniform in expressing the patient's wishes, and so it's not. I'm not aware that one would trump the other per se. I think we use that, as we're gathering data to help our decisions, we would use both of them.
Okay. Just curious, because I know that's another tool in the toolbox that people can do. And particularly that form requires them to sit down with you. That's not something that we can do as an attorney or somebody downloading one off the internet. That has to have a physician's signature. Is that correct?
Correct.
All right. Any general last thoughts or any advice you would give to people as they are thinking about doing a healthcare directive? Any kind of last words for folks?
Yeah, I think the biggest piece of advice I can give is to do it, to sit down and do it. I have plenty of patients who have done it, and they haven't had any ill effects as a result of doing it. And certainly they do it with the intent of limiting anxiety and distress amongst their family when that time comes. I also have plenty of patients who I give them the form and it sits on their desk. And then when I ask them about it in subsequent years, they say, yep, I know right where it is on my desk and I haven't got to it yet. And so I encourage people to do it. Again, this is a great time. We're all somewhat cloistered in our homes, and this is a great time to do these sorts of documents.
Okay. Well, Chris, if somebody wanted to get a hold of you and asks you questions, how could they get a hold of you?
Sure. My office number is 320-685-3020. And my email address is cjw@cjwennermd.com.
All right. And I'm Kelly Springer. I'm an attorney. If you have questions about healthcare directives or any other associated estate planning, you can call our office at 320-685-3678 or kspringer, KSPRINGER @willandbring.com. Thanks for joining me today, Chris. I really appreciate it. And hopefully we'll get lots of people to do their healthcare directives.
Thank you, Kelly.
Thanks.